All right. Hello, everybody. My name is Andre. I am a registered massage therapist, traditional Thai massage therapist, Chine Song therapist, if you know what that is. If not, look it up, check out my website, or just Google it and you'll figure out all the information. So we're here for low back pain. Surprising, we have someone in the room with lower back pain. I'm guessing this is the most common thing that almost everybody in here sees as a massage therapist. So what's the cause of lower back pain? There's so many causes, from facet joint irritation, from muscle strains, from bulging discs. There's a myriad of reasons that people get lower back pain. So I like to simplify things, maybe oversimplify things. And since we've got wonderful practitioners who are going to come up here and demonstrate some more things, I'm not necessarily going to treat her sciatica, her complaint. We're here for lower back pain. The two are definitely tied together more often than not, but I'm going to show you just a very general thing that I would do for lower back pain and my explanation as to why this works for almost every type of lower back pain that exists. So what do most of us do all day? Well, maybe not us, because we're massage therapists. We're on our feet, we're moving, we're lunging. We get a lot of movement. But for the majority of people in North America, what do we do all day? What I'm doing right now, sit at the computer, finish your 8-hour shift, 9, 10, 12 hours nowadays. And then what do you do next? You go home, maybe you make your dinner, and then you sit down on the couch. So what happens when we're sitting? Well, let's take what happens when we're standing first. When I'm standing, iliopsoas, pretty much at the level of my belly button, and it attaches in a weird little place down here, lesser trochanter, right? Look at the length right now of this muscle. And now look at the length of it. I can touch both attachment points with one hand, my thumb and my index finger. Watch what happens when I stand up again. That is a huge difference in length. So what are we doing when we sit down? Contracting all of that tissue. What happens with the fascia, the connective tissue? It starts to become adhesed. And then when you stand up and you try and stretch that muscle, it doesn't really have the ability to do that in the same way. So internally, we're being pulled, twisted. And that's if it happens on one side and not both. So first thing I like to do with lower back pain, and again, let's keep in mind, this is a generalization. We're talking about lower back pain, right? There are many, many different reasons for it. So it's not always as simple as saying, let's just work this muscle at this point. But as a generalization, what I find from experience, you go and you work in their iliopsoas, the overwhelming majority of people will instantly feel relief. So how do I do that? Because I do Chine Song and because I do Thai massage from the belly button, if we go 2 finger widths adjacent to the belly button and we press right beside the belly button, 2 inches below, 2 inches above, this is not only iliopsoas points, but it's also kidney points, and kidney points also relate to lower back pain. So I'm going to get you to lie on your back. Yes. And I'm going to ask her some quick questions about contraindications, but we don't have to do that. Anything painful, uncomfortable, just let me know, okay? We're going to go in very gently. And I'll stand on the other side of the table so you can see what I'm doing. Generally speaking, when I first see someone, I want them to lie on their back with their legs out. Not the best position for the lower back if you have hyperlordosis. So if she feels aggravation within the first 30 seconds of lying here, that tells me something. That tells me hyperlordosis is a part of her problem. And is that the case? Has your back pain gotten any worse or better since you started laying down? No. Okay, so what I'm going to do anyways is bend one knee. If she had her lower back pain start, I would pillow her and make sure that these legs are up. Since I do Thai massage, I don't rely on pillows as much. I just get in position and you can relax down. Point to your belly button for me. 2 finger widths, I'm gonna eyeball it. Nice deep breath in. I'm gonna get my fingers here. As she exhales, I'm gonna sink gently. Now, if I'm being honest, looking at her and her posture, I don't think this is the main culprit of her lower back pain. But again, we've got other educators that are going to come here and show you maybe something more specific to what she's dealing with. But for the majority of people, this will work. Nice deep breath in again. We're going to go down about 1.5 inches, 2 inches. And now when I hit here, I hit resistance. The first 2 points, I didn't feel much resistance. Now I do. So I'm going to sit here as long as she's comfortable. How do you feel? And let me know when my time's up. I don't want to take time from anybody else. All right, nice deep breath in again. Exhale, and I'm going to sink right in again. You will feel a pulse in here for most people. You've got the aorta coursing through here. Not a big deal. And what can you see with her right now? She's not very relaxed. Let's drop those legs down. Drop, 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 drop. And you know what? Since I don't think this is actually the main culprit, I'm going to do a little bit of quick treatment since I'm in this position. I'm going to drop down. Relax. Okay. Other thing we can do, low back pain. I do Thai massage, so I'm all movement based. After I do those techniques, I'm going to start to check. Drop that knee, drop that leg for me. Good. I'm going to start to check the rotation and the mobility in and around her hip. Wherever I feel that restriction, as soon as I push medially into rotation, I feel a straight band, a straight line going straight down into a greater trochanter. So now I would start to do some work around here. I do Thai massage, so I'd get my knee and I'd very gently just start to work along that line. Call it an energy line, a Zen line. That's what we work in Thai massage. Do some, I know, they're going to take care of you. I'm just going to showcase a few things for everybody. All right, drop that leg down. And we can see how much apprehension when people have pain. So if I put her in any position where she's not able to relax, I'm going to immediately change that position and make sure that she's fully relaxed for what we're doing. Distraction, drop the knee off the table. I'm going to hook her leg and I'm just going to lean forward. And you can see her whole body is going to pull with me as I do this. It's a nice little distraction for the lumbar spine. It's a good break and stretch for me as well. And typically what I'll do after that, because a lot of lower back pain has to do with instability in the hips. So I'm going to get you to turn on your side real quickly. Either side. I would do the assessment to see which side needs it more. Generally speaking, I'm going to assess both of them through palpation and visually. I'm going to get you to straighten that back leg. Come back towards me a little bit, please. Great. Bend this knee up 90 degrees. Bottom one straight. This one straight. This one up. There you go. And in Thai massage, we call this the golden triangle. So I'm going to go into glute medius and just very gently assess and start to compress and work these areas here. Main two things I always touch with lower back pain, iliopsoas, glute medius, almost every single time. And those two alone will fix lower back pain for, I would say, about 90 to 95% of people. And if you do it a couple times in a row, I usually tell people twice a week for 2 weeks, that will eliminate most people's back pain. It won't come back. Some people need a little bit more, others that's good enough. But I'm gonna let all these other wonderful educators come up here. Thank you for your time.
Hello, I'm Magnus. What's your name? Prem? Okay. So we're both structural integrators. And I would have to agree with Andre on when you look at low back pain, can be a lot of different causes. We look at psoas, we look at the hip flexors. Obviously inactivity can cause low back pain. You know, what Andre was talking about was the shortness in the hip flexors when we sit down. Overactivity can also tighten psoas, which is a main culprit. We look at the front body a lot. We're an flexion addicted society. So a lot of our flexors, whether that's biceps or whether it's our psoas, our hip flexors, tend to get short. So we tend to focus on that first. And then we will also go into the glute muscles can be another big culprit. But I want to look at your standing. So if you just stand and face the audience. Yeah. So we work away from the pain. So we're looking at anywhere from the feet, through your pelvis. Can you actually, if you turn around so they see your back, and then just put your hand where you're feeling the pain right now. It's on your left side, and it's more on outside and front. Yeah. In the front on both sides when you're standing or sitting? Mostly on the left, okay. So turn your left side. And also she's pointing to the feet, and we're always looking at the feet. The feet is your foundation, so whether it's low back pain or knee pain, we want to make sure there's a great foundation. If you face the audience again. So I'm also looking at her toes. Yeah. So we look at mainly the right big toe, but the left big toe as well goes in towards the second toe, right? So that foundation, does not help her being upright. So it's definitely something we want to look at. And now let's look at the left side. Now we're going to look at the pelvis. Turn your left side towards the audience. She also likes to stand with her left foot further back. So we know that the pelvis is not perfectly balanced, right now. And also, if we look at her pelvis as a bowl, we have an anterior pelvic tilt. So if you think of the pelvis as having water inside, the water is tipping over. So let's have you on your back. So you put your head here and you put your feet down there. So here's Bobbi. Yeah, you can lay down.
You hear me?
Yeah.
Okay. So one thing we want to talk about is body mechanics. So go ahead. He asked you to get on your side, right? Or would you? Tara was so wonderful talking about intuition. So raise your hand if you know you're a person who has a come from that is already from your own intuition and you feel solid in that. Okay, I saw a couple little spikes like that. So the main thing for us to understand anything is to really be embodied. It's not just about thinking things through, because then we tend to get educated and we think we have to follow exactly what that was that we learned. So what we want to do is take in information and then embody our come from. So our true essence, our soulful self. So when we do that, we can be in our body. So I want everybody to take a nice deep breath. Inhale, but when you inhaled, did you move from here or are you moving from here? So take a deep breath in, and I'm taking a stance that we would have when we work. So let's look at Magnus's work and let's all breathe and let's get out of our head and just take it in and let that match who you are right now.
So what I noticed here, just little assessment. You okay? For one thing, the left leg was shorter, and there was mainly fascial muscle tightness. Here is a little bit of rocking. That already feels, I don't know if it feels better to you, but I feel more movement. This left leg was not moving very much. It's stuck in the knee. So just this little rocking technique can tell me a lot what's going on. Andre's already done some work on the abdomen and the glutes, so we're not going to go up there. But that's definitely something we would check into. So this right leg actually feels tighter right now. You feel that as well? Yeah, but now this feels a little looser. I don't know if you can tell the difference. So coming on the right side here as well. Let's see if I can do this so you can see. That's good. So I'm pulling with my left hand and I'm pushing. So this is what Adderall called the log roll. And we normally do this on the skin, but it can be done as well through the clothing. Do you feel a little bit of a rotation? So we find that rotations are also very important as far as stabilizing the pelvis. And we'll do one more. So I'm pulling with the right hand. I'm pushing with my left. You should feel a little bit of a stretch.
And while he's doing that, we like to ask our clients, hey, take a deep breath. And if we find that they don't know how to breathe with the diaphragm, we instruct them, because then they get to take that in their life. Stay in that parasympathetic as much as possible.
And I can also check her ASIS, blood pressure, okay? So we've already done some work on the abdomen, so I'm just sinking on that left ASIS just to see. And actually the right hip actually feels tighter, but most of your pain's on the left side, right? In the sciatica. Depends, it could be on the right as well. So the left one is sinking a little bit. So just a bounce test. The right one feels pretty stuck to me. Okay. Oh, so left side is working harder. Yeah, this hip doesn't feel like it's moving at all. So we'll look at the legs again. And now the leg length actually is even. That's all it took. I mean, it's rare that it's actually the bones that are not the same length. It's usually some kind of fascial tightness. Now if I bend your knee, is that okay? So we can also check, is that okay? External hip rotation, and we can check internal. So she's a little limited internal. And we'll go back to external. We're going to check the other side as well. I don't know how we're doing on time, guys.
You've got about a minute or two.
Okay. Now, she has a lot more internal rotation here. So we also look at the joints. So this is actually in range, about 35, 40 degrees internal hip rotation. She's tight external here. This is tighter. Can you feel that as well? So there's a little bit of an imbalance. We go back to the right side. Okay, good. She said the pain below her ankle is gone. Combination of what Andre was doing and what I'm doing. So here is external. She goes a little further, still tight. Here's internal. We could go in and just enhance that internal rotation a little bit. I'm doing with my right elbow and with my hands. So I'm rotating. And I can also push down, a little bit of decompression. Very gently. So rotation and a little bit of compression. Is that okay? And I can also do just a little bit of a decompression as well. So this technique here is not an Adderall technique, it's not a fascial technique, it's more of a joint range of motion. But we know that tightness in the hip joints can definitely affect low back pain, sciatic pain. Does that feel okay? So now I'm doing decompression and we're coming back. We're checking the leg length again. Looks better, looks more even. The right leg is moving a little better, a lot of tightness in this right knee. So that's something we would have to address.
So this technique Magnus is using is also an assessment technique where you can understand what's going on in the joints all the way up the leg into the hip.
Okay. So there has to be more work on opening up the rotations in this leg. But let's have you sit up and just see how you feel.
And stand as well when you're ready. Look at that smile.
Yeah. So again, I'm looking at the big toes. Does the right big toe look a little better? Possibly.
Look straight ahead so that they can see your alignment.
Yeah.
And if you could turn to your side, face that way.
Yeah.
I don't know if any of you noticed earlier, but she was really buckling on this side and she's much straighter. Her leg is underneath her better.
Yeah. The right big toe is going to take some work, but we can change that positioning. That's the thing. A lot of people have surgeries and for these type of things, but a lot of times in our practice, we can actually reverse that and get it to actually also look better, not just reduce the pain, but actually reposition that big toe. And I think that's a big part of your sciatic issue going on, starting in your feet would be my opinion.
Awesome.
Okay.
So you guys, I want to finish with letting you know that we teach body mechanics and we're really big on that. Massage therapists tend to work like this and hover over and they wind up really being jammed in this area of their body and they wind up having pains, everywhere. So we teach longevity for you guys with proper body mechanics that go along with this type of fascial work that we are working with. So thank you.
All right. Thank you. And thank you.
That was awesome.
Good.
So has everybody seen a show called The Simpsons? Yes. So, hi everybody. We're gonna have to do better than that, okay? Hi everybody. Hi, Dr. Nick. All right, I'm gonna be your host and go through a little bit more low back stuff here for you. Most of you may know me from the 20 plus books that I've written. You know that I'm evidence-based and functionally based as well. And I think one of the best things we can do is give you good functional capacity. So Ms. Premla, if anything I do is too much, you let me know right away and we'll modify what we're doing. Are you cold? You want to wear this or are you okay to take this off? Your choice. Doesn't matter. Yeah, just leave it on. Okay, perfect. Okay, I'll have you stand up facing me. I would encourage you all to start with a great neurologic assessment. What are you going to do? Silence. Active range of motion, okay? Every single patient. How many of you are doing active range of motion with every patient? Okay, if you're not, put your hands up and just lie to me, okay? All right, just lie to me. How many of you have this patient, literally, the door opens and then the shirt's off and they're on the table before you know it, okay? Okay, you are that patient, perfect, Mark, okay? You have a huge opportunity to already improve function and make your treatments way more effective. So all I want you to do is follow the range of motions that I do and we'll see how you move. And if anything's too much, let me know right away. If it's painful, it's okay. But if it's going to cause you further injury, that's when I want you to stop. Very important words right there. Why do I say if it's painful, it's okay? You're trying to trigger some kind of interaction for sure. And oftentimes people will stop where they think it's painful, not where it's actually painful. So I can already improve your function by just doing a basic range of motion assessment. So again, we know we sciatica and low back, we'll kind of see what your bias is, but leaning to the side here like this, as far as you can. Oh, that's actually pretty good. Okay. And even the smile, the coy smile is good too. Okay. All right. I'm saying, what's that? Something behind you. Turn around, look behind you. Okay. All right. Excellent. And what's that the other way? Okay. So those are good checks right here, but we know really for low back pain, usually sciatica type issues, the flexion extension is going to be our real check. So I'm going to have you support your low back, leaning back like this. How do you feel there? Does it feel good? Does it feel bad? It feels tight, but does it actually feel like it's a better position or a worse position for you? That can't say. All right, let's have you bend forward and touch your toes. See what you can do there. Okay, let's have you bend forward and touch your toes as low as you can go. And then how does, even let your head drop as well. How does that feel overall? Yeah. So she feels very good when she touches her toes. What do you think my treatment should probably include? A flexion bias that she likes right there, right? So we're going to do more flexion like that. All right. So a couple of other things that we're going to do is I'm going to have you lay on your side. I'm just trying to think for the cameras to see this. On your side facing that direction, actually, if we can. Okay. So a couple of things right here. You're going to lay on your side facing this way. There's a bunch of different ways you can take these cases. Ideally, we'd have everything set up with nice pillowing and stuff like that. But just to start with, what I'll usually do, yeah, thank you, sir. Okay, bring us up, perfect, is we're gonna bring this leg forward and I'm gonna have you slide your hips a little bit more this way, actually. I want you to come all the way this way. And I'm doing this so the camera can see it, so you can all see what I'm doing, but I often do a check for people with sciatica just to see what their range is to begin with, because ultimately, when you injure your low back, we've heard it from all the other practitioners here, what do you stop doing? You stop doing little movements of the low back. So I'm trying to show her that this can be a safe movement to do. So it's gonna be a little bit awkward because my back's this way, but what's up, bro? Bro, okay, leave me hanging. All right, and we're gonna do this. And you see the interaction right there. Okay, so there's a couple of things. I will do this even with my grandma patients and everything like that, and they're like, he called me bro. Okay, something like that. Wow, we were teaching in India, and in India, it's very formal English. So we would do this, I'd say, what's up, bro? And all the people in India would be like, how are you doing today, sir? Can I have you do this? Okay, but whatever, it's little tricks like that. And just so you guys can see, I'm gonna block you a little bit, but what I ultimately wanna do is I wanna distract her low back just a little bit to give her a little bit of length right there. And I wanna bring her leg down like this. So all this is going to be is a way to distract and twist the low back. Now in acute sciatic cases, I'm even gonna bring your hips a little bit closer to the edge. You're safe, I got you. But if you feel like you're gonna fall, let me know. No, yeah, exactly. Felt like that was planned, okay? Wasn't it? Okay. All right, so even this movement right here, big breath in. We already heard about the breathing with the diaphragm is gonna be great. And as she breathes out, then you're gonna give that load and movement right there, okay? And how does that feel? A little bit of a stretch maybe? Big breath in again. Breathe with your client as you're working and then breathing out. And every time you do it, you can bring her a little bit forward and more into that range. If you do it with breath, just like we already saw, you can challenge people a lot more into those ranges. But we can do more than that. I'm gonna have you lay flat on your back for 1 second and we'll see the relevance of this here. What is the standard test for sciatica? What do you do? Straight leg raise. Everybody should know it's one of the most well-researched tests. 2 minutes? Oh, no, it's telling me camera too. Okay, so tell me 2 minutes. What's up? Peace out. All right. Okay, so you're gonna do a straight leg raise. You're gonna bring the person up. Oh my gosh. This is not even bad right here, okay? Can we pretend like this is bad, or what do you feel? It hurts. Oh, you feel this more in your hip though. So just wait, we'll come to that in a second. Let me run the low back scenario here first, and I'll come into the hip stuff here in a second, okay? Regardless, for most patients, if they're gonna have some type of sciatic issue, they're gonna usually give you somewhere right in here, and they're gonna say, oh, stop right there, numbness and tingling starts. That's a pretty standard picture. You have a couple of options. You could reconfirm by bending the knee, bringing the person up, and then stretching out. But I'm going to suggest to you that assessment is therapeutic. You can use the straight leg raise as a neuromobilization strategy if you wanted to. And all you literally have to do is take the person up a little bit, expose them to the range of discomfort, and then back out. And look for habituation within that movement, okay? Beyond that, we know, and I can show you this on our cadaver dissections that we do, I know that if I lift your head up, does anybody know what the name of this test would be if I lifted her up like this? Well, you could call it a slump, or you could call this a maximal straight leg raise test right here as well. And you're looking for different ways that you can trick the person's nervous system to move into these ranges they don't think are possible. So you can cycle back and forth with the leg, you can cycle back and forth with the head a little bit, but I'm going to incorporate that into that mobilization that we just did. So we're going to have you lay back on your side this way, and the setup is going to be the same setup. Sup, brah? Bam, and she knows, okay? Now you got it, okay? And you think that I'm joking here, and I am, but a big part of it, does everybody see Premila's smile? Okay? You heard Tara talk about this as well. Her smile is half of the treatment right there, all right? People, when they walk into your clinic, what should they do right away? They should have smile. Like, imagine if you greeted your patient like this. Oh, yeah, great to, guess I'll see you today. This is gonna be great. Okay, versus the big smile and everything like that. You're gonna see better outcomes just because of that. All right, changing the straight leg raise into it a little bit more. So last time we did it, and this is where I would start, especially in acute sciatic conditions, with this distraction and moving the leg over like this. I'm standing to the side so you can see it. I'd really actually stand more like this and use my body weight. But if I was going to change it, what I would do now is take this leg, make it be straight, hook it with one leg, and you're okay. And we can go from here, same movements, and you can control from your back leg. Oh yeah, good. So you can feel the range here. You actually have really good range, something like that. Then my forearm comes over top, and we can start to really stretch your low back out in these positions right here. Yeah, and you can feel that reach right there. I'll do the same thing on the opposite side so everybody can see what I'm doing as well. So we'll flip you over this way. Yeah, I'll come over this way. I know it's the opposite leg, but it's so everybody can see it. Okay, and one of these. Sup, brah? Okay. Oh yeah. What's her underwear for today? Okay, we're not gonna have a reveal here today yet. Okay. Okay, that's the later show. Okay, so we're set up like this. Now you'll see my mechanics a little bit better. I actually want, well, you know what? Just wait. I will do this for some patients as well, depending on where you feel the restrictions. As long as you don't have significant shoulder instability, I'm gonna bring this arm all the way up like this, and I can do a long axis stretch where I'll actually hook. Okay, so when you're doing these setups, you want nice soft hands wherever you can. I'm gonna do a nice tissue pull, grab the front of her delt, traction up and away. If it's too much, let me know, because the stretch is gonna get deep here in a second. But you'll be set up like that, so you can feel that lift and move right there. This leg is gonna come down, this lift and move right here. And actually, I wanna keep it here just for right now. Just keep this hooked in the back of your foot, or back of your knee. Yep, good. I know, this is a good one. Okay, and then the same thing, big breath in. Let her unwind, and then as she breathes out, you sink in with your body weight. And so a couple of things that you can see that I'm doing. I should have said this. How have I gone? I can't believe this. 5 minutes without talking about Brazilian Jiu-Jitsu. Okay, how many of you do Brazilian Jiu-Jitsu? Hands up, perfect, okay? What do you know is gonna win? You gotta get your body weight over top when you're doing this, right? So if you see, I'm putting my body weight over top. Okay, we'll show you one more thing for the sciatic pathway on this. I'm gonna get you face down. I'm not 100% sure on how to lower this, but yeah, okay. Coach has got me right here. I'm gonna be buying one of these tables, actually. But shall I face down? I am teaching tomorrow morning the instrument-assisted class. Anybody who wants to take it, Shazam right here. We're gonna be going through some of these. Yeah, sorry, however you feel like you can be comfy, Ms. Pramala. Yeah, something like that. Okay, how many of you have aching thumbs? Okay, that would be me after 20 years of active relief, spin and stretch and all that kind of stuff. This literally is the shape of my thumb right there. So what you can do now, and we do this with a lot of our pro hockey players and stuff as well, is you can anchor in and generate really good force to sink past the glutes, get around piriformis, get around the sciatic nerve and all of that. Instead, if it's too much, let me know. We can sink in and start to move our way through here. Pressure's okay. And I would even do these as side posture treatments as well. where I'm anchoring in, and your force is like 30 times what you can generate with your own hand. And how's that for pressure? Tolerable? Yep. Okay. We're always looking for tolerable. Okay. Better than tolerable, but something like that. And you can work your way through. Yeah, you can feel that edge right there as I come just off the edge of your sacrum, right along that attachment point. So I would often use the instruments and start to sink in as well. I know we only have 8 minutes, but that's kind of what I would run through. And then, how do you want to finish your treatments? Patient education, maybe a range of motion check again or something like that. So we can have her back up and stand up. Okay. I know this is quick because we had 8 minutes, so we're jumping around here. Okay. And all I'm going to have you do, Ms. Premla, is face me. Yeah. Okay. Fix the pants, face me. And we're going to do a flexion extension again. So you can go ahead and extend back if you want. And how does that feel? You can see, yeah. Yeah, well, you can see you can do it, but you could actually bring your head back a little bit further and then bring yourself forward again. Yeah, down to your toes again. And everything is pretty good there. So you can see you actually sink in a little bit better too. And then I would finish it off with, hey, here's this book on low back pain that you should go ahead and read with 100 different exercises. Do these exercises and away you go. Thank you very much for your visit, and we will see you in the future. Bye, everybody.
Okay. So the first thing I'm going to say to set the stage is that, yeah, grab a seat so you're comfortable. You don't have to stand forever. Don't worry about it. The first thing I'm going to say to set the stage is that every individual is going to have signs and symptoms. Signs are what everybody can identify, including the patient. Symptoms are what only the patient can identify. So a runny nose is not a symptom. It's a sign. Pain is not a sign. I can't identify your pain. Can you feel what my low back feels like? No. Some people would claim that they can. I can't feel what your low back feels like. All right. So I have no choice from the position that I'm working to work on sign. Now, the signs that I have access to are going to be quality and range of movement. I'm going to see asymmetry with my eyes. I'm going to feel restriction to movement with my hands. So I'm going to put those together in what would be termed multisensory integration. So I'm going to use multiple senses to build a larger picture to the best of my ability. So your complaint is sciatica, correct? Plus more. Well, what more? A lot more? Okay, where is it ouchy? So you tell me what you want to tell me. Okay, feet feel a lot of tension constantly. Okay. 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 So gait issues, yes. Okay. You got bunions. Yeah. Yep. Right on. So we've got a lot of stuff going on. So obviously we're aiming at talking more about low back pain, but there are other complaints. Obviously the body is an integrated unit, so everything's connected, no duh, right? I'm concerned about where it's not moving because that's the thing that I can find and that's the thing that I can interact with. It matters to acknowledge and take into account that the patient has symptoms. They have something to tell you. What you find may not relate appropriately to what they feel. What you change may not relate appropriately to what they feel. If you judge yourself on what they feel, you will feel like a failure almost all the time. If you judge yourself and your success based on the movement change, you'll have an honest scale that you can interact with. The patient scale matters to the patient far more than anything. So you definitely feel pain, right? Now, what I'm going to do is I'm not going to make any assumptions. I'm going to do a really quick screen to figure out what I can figure out as quickly as possible to try to differentiate between the low back and the hip, right? Because that's the area that we're really trying to focus on for the mastermind. And we'll see to what degree it may or may not have an impact on the way the feet feel. So if you just sit on the table as comfortably as you can, so just support yourself. Thank you. And I'm going to take you for a little ride. That's the wrong way. No, that's definitely the wrong way. I did it twice. There you go. Nice and smooth. Okay, so if you're comfortable, what I'm going to do is I'm just going to have you bend to your left. So like a little teapot to the left, the whole body if you can. Fantastic. And that, yeah. Well, don't lift a cheek. So yeah, there you go. There you go. So now we have an idea. The reason I say don't lift a cheek is because when the patient's pelvis shifts, you get a different view. We'll have you bend to your right as comfortably as you can. So a little teapot. Okay. Now, does everybody agree that does not work as well? Right. So do it again. So letter C to the left. See what that looks like. Letter C to the right. Okay. Does everybody see that that's not the same?
right? So essentially when she bends to her left, it's okay. When she bends to her right, it's not as good. So I've already figured out that the motion that I'm concerned with is that the motion on the right side of the low back is not the same. Right? We're gonna have you lay on your back if you're comfortable. Yeah. So, and this is the thing. So she said they're both really tight. This is where what I'm concerned with and what she's concerned with don't properly match. I see the problem as the movement to the right, but she feels that regardless of which way she moves, it's uncomfortable, right? Now, I can't work on that, but doing anything other than acknowledging that and being respectful of that is disrespectful. So we just check the legs. I want to make sure whether or not I'm concerned about the legs. So simple internal, external rotation. I check adduction. I just want to see which hip is giving me the trouble. There you go. As far as funny stuff, the right leg did two funny things. I got a finding in the right low back. So it's about the resistance, right? So the movement's not terrible, but I got a little hiccup in it. So my immediate concern becomes the right low back and the right hip. Are you comfortable laying on your stomach or is that uncomfortable? Are you sure? Okay. All right. We'll have you lay on your stomach for a moment. Okay, so I'm concerned about the right side of the low back and the right hip. I'm just going to get access to the hip. So if I'm going to look at the hip, I want, or any piece of anatomy, I want it to be exposed, free to move in the plane or planes required, and preferably visible. I like multisensory integration. So I'm on the wrong side. That's the right hip. Okay, so I'm going to come over here. I'm just going to get a real quick check. No, I was on the right side. See? That's why you don't trust me. And that's why I check stuff. So we get to end range of motion. That'll move a little farther. So the right hip is showing me things multiple times. All right, so I'm just going to check through the right hip. And I'm also paying attention to how she responds. So if I move too far, I start to get auxiliary movement. I don't want that auxiliary movement. I don't want the low back to move. I want to be able to work on the hip. Now the challenge becomes that as I do this, she's going to respond in varying ways. She will resist the movement. She will accept the movement. The tissues could jump. If the tissues jump, I'm doing it wrong. My aim is to have her feel as little as possible and not have a requirement to protect herself. If she has to protect herself, I'm doing it wrong. Protection is identified by any abrupt response to any movement, right? So whether it's a face, whether it is a sound, or whether it is a contraction or a jump, I'm looking to avoid abrupt responses. So this is very, very unspectacular. I'm just holding on to the tissues in the region of the hip. So essentially what I'm looking at is a still muscle and a still pelvis and a moving femur or a moving hip, right? 2 minutes? Word. Thank you. So I just work through here, trying to loosen it up. Now, maybe I get a response from this, maybe I don't. The easiest way to check, and sometimes the direction of movement is counterintuitive to what you found. You have to work based on how they respond, not how you assume based on a preconceived idea. So I just work through here. Maybe I get a response, maybe I don't. We have to be respectful of time because other people have work to do. Right now, as I bend her knees, there's a little bit of resistance, a little bit of discomfort. Now, it's hard for everybody to see. These are more even at the moment. So very, very small amount of work, very unspectacular work. Are you comfortable laying with your right side up? So you'll be facing me. Can you do that? Okay, because what I want is access to the right side of the low back. Watch your fingers so I don't pinch them. Yeah, there you go. That's okay. I'm going to be over there anyways. I'm going to block it. So what I want to do is have access to the lumbar column, and I want to use the leg as leverage. So shimmy back towards me if you can. Yep. And then you can put your head on the headrest. Is that okay? Yeah. And if you want to slide up the table, it might even be more comfortable. Is that more comfortable? Okay. Well, you matter, right? We're going to have you bend your knees, because if your knees are straight, it's easy to roll off. Not so hard. Yeah. That's perfect. So here, I just want to check right side bending because I want to work on this. Right, so I can just tip the pelvis over the lumbar spine. So essentially, I'm bending the lumbar spine from the bottom up, just nice and easy, nice and relaxed. Now, if that gives me some of what I want, I'll take it, but it's not really giving me all of what I want based on how it's responding. I'm going to use the lower limb. I'm going to hold on to it. I'm going to be as close to her as I can. Now, to get close, I'm going to put myself on the table. Stay here. Now, the idea is, if she resists the movement, I have to change something. So sometimes I have to change the rhythm of it. Sometimes I have to change the intensity of it. Sometimes I have to change the range of it. Sometimes it's hard to find. The first time you meet somebody, you very rarely give them the keys to your luxury vehicle and let them drive it. So if I ask her to relax, the answer is going to be I am, or I would if I could. So I don't ask. I give her the opportunity to learn to trust me by how I move. I don't engage anything too strongly or too fast. right? So these are very, very small movements. You can see that I can push this hand in the lumbar column. I can use the hip as the lever and just do small amounts of work. And if she jumps, I change, okay? So we're gonna do a little bit of work here just to try to figure it out. Now, what I'm gonna ask you to do is I'm gonna ask you to sit up and face the crowd, okay? Please excuse me clearing my throat, get lots of pops. Yeah, and if you just slide back on the table so you're properly supported, thank you. Okay. Now, what we're looking for superficially is a change in that test. Okay, so we bend to the left because it was the better way. So we'll have you bend the body to the left. Yeah, whole body, keep going if you can. Good. And there's still tension on the right side, which is expected. We'll have you bend to the right. Same deal. Now, is everybody able to see that there is some change in range of motion? Right? Come back. Now, the change in range is what I'm looking for. It's not gigantic, obviously, based on time being limited. There is less that I was able to do. So we have some result, but not fantastic result. Qualitatively, how did it feel when you bent like that? Did it feel better? Feels much better. So with small visible change, the internal sensation has improved. So this is a case where what I did, what I found, and what she feels match well. Stand on up and see what happens with your feet. They may feel exactly the same. They may feel different. Do they feel exactly the same or do they feel a little different? It's okay if they feel the same. Don't worry about it. It's not going to hurt my feelings, I promise. They feel more grounded on both sides, right? So I have to take her input because that's what she feels. I avoid coaching the response. I avoid saying, do they feel like A or do they feel like B? So you tell me how they feel, and whatever you express is what you express. So with very, very subtle, small amounts of work based on the finding, we work on that. Now, I didn't check the hip again, and we don't have to do that, but we made, with very little work, change in your back. And you didn't feel almost anything, did you? Right? And every time you felt like you wanted to pull a little bit and protect yourself, I changed how I moved. Is that consistent with what you felt? Yeah. So at least in this case, I said something and I did that, and we got some change. So regardless of the condition, you check things, find how they present, and you work on the movement problems that you find. Anything that you're interpreting under the skin, you're making assumptions. So if I talk about a particular muscle, I'm making an assumption. If I talk about a particular nerve, I make an assumption. If I talk about the movement problem that I found in the environment of observation that I found it, I can be accurate, right? So I'm not going to talk about a particular muscle because I don't know that, and I can't know that. If I could see your muscles, you should call 911. So if I know it's this one for sure, obviously there's areas where you can be pretty sure, but anyways, you feel a little bit better from everybody doing wonderful work on you. Thank you for participating.